How should we characterize carotid stenosis on CTA beyond stenosis grading? I'm Francis Deng, the AJNR podcast editor, and this episode highlights two papers published in the journal this past year on CTA-based Carotid Plaque-RADS. Before we get to that, let me orient you to Carotid Plaque-RADS in general. This system was introduced in 2024 in a publication by radiologist Luca Saba and colleagues in the Journal of the American College of Cardiology Cardiovascular Imaging. The goal is to move risk assessment for cerebrovascular events beyond just luminal narrowing of the cervical internal carotid arteries. We're all very familiar with making the NASIT-style stenosis measurements, but it turns out this grading does not capture all the stroke risk in patients who end up having a large artery-to-artery embolic stroke. So the stroke imaging community has had increasing interest in looking at plaque composition and surface disruption markers as well. Plaque-RADS tries to standardize that into a rating system. The system was intended to be able to be used across imaging modalities, although some features are best assessed on high-resolution vessel wall MRI. Let's briefly review what the system is. So there are 4 grades, grades 1 through 4, representing increasing vulnerability of plaque and associated stroke risk. Plaque-RADS 1 is a normal vessel with no visible atherosclerotic plaque. Plaque-RADS 2 is a thin plaque defined as maximal wall thickness less than 3 millimeters. And this plaque can be made of lipid-rich necrotic core, calcification, or both. And Plaque-RADS 3 is thick plaque or ulcerated plaque. Thick plaque is at least 3 millimeters in maximum wall thickness on cross-sectional images. And on MRI, you can subclassify this even further by whether there's an enhancing fibrous cap that's thick or thin. Plaque-RADS 4 is the presence of any complicated features, either intraplaque hemorrhage, intraluminal thrombus, or on MRI, the rupture of a fibrous cap. So a significant limitation of the full Plaque-RADS framework is the need to do high-quality vessel wall MRI to assess for all these features. But this technique simply is not widely deployed in current clinical practice, and the workhorse of cerebrovascular evaluation is still CT angiography. Enter CTA-based Carotid Plaque-RADS. So this is a simplified version of Carotid Plaque-RADS that removes the need to assess the fibrous cap. So let's go through the grades one more time, as hopefully repetition will help you learn this grading system. Plaque-RADS 1 is no plaque. Plaque-RADS 2 is thin and uncomplicated plaque that has a wall thickness less than 3 millimeters. Plaque-RADS 3 can be either thick and uncomplicated plaque, meaning at least 3 millimeters maximal wall thickness, or an ulcerated plaque, which on CTA is defined by luminal contrast outpouching at least 1 millimeter into an area of wall thickening. And Plaque-RADS 4 is either intraplaque hemorrhage or intraluminal thrombus. Now, it turns out that intraplaque hemorrhage is not totally reliably assessed on CTA, as it has a lot of imaging overlap with lipid-rich necrotic core that's without hemorrhage. But some CT-based surrogates have been defined. And these are either a very low attenuation, less than 25 Hounslow units, if you draw a region of interest in the plaque, at least 2 millimeters square in area, or the presence of a rim sign, which is the presence of thin adventitial calcification at the periphery of a soft plaque. So that soft plaque is at least 2 millimeters thick, and the adventitial calcification is less than 2 millimeters thick. So those are features of intraplaque hemorrhage, or at least the CT surrogates of that, indicating a carotid Plaque-RADS 4. And then finally, intraluminal thrombus is the highest risk feature, and that's seen as a filling defect that's based at the plaque that projects into the lumen and is surrounded on some sides by contrast. So let's take a look at some examples from our first paper, again with some repetition to help you learn these grades. In panel A, we have smooth, regular contours of bilateral internal carotid arteries. So this is carotid Plaque-RADS 1 on both sides. In panel B, on the patient's right, there is plaque, but it measures less than 3 millimeters in thickness and doesn't have any ulceration or complicated features, so it's Plaque-RADS 2. In panel B, on the patient's left side, there is a thick plaque. It's more than 3 millimeters in thickness. It measures 3.7 millimeters on this axial image, and it's completely calcified. So that's carotid Plaque-RADS 3. In panel C, on the patient's left, we have a thick, soft plaque without any calcifications, and the plaque measures 3.4 millimeters in maximal wall thickness. And if you put an ROI on it, the attenuation was not less than 25 Hounslow units, so this would be another carotid Plaque-RADS 3. Also in panel C on the patient's right, we see another thick soft plaque, but this is a little bit different. If you put a region of interest on it, it would measure less than 25 pounds per unit. And this also has this thin peripheral calcification. That's the rim sign. That's calcification in the adventitia. These are CT surrogate markers of intraplaque hemorrhage. And so this would be classified carotid plaque-RADS 4. Over on panel D of this image, we see a soft plaque here on cross-sectional image measuring 2.7 millimeters. So you might think this is carotid plaque-RADS 2, but in an orthogonal plane on this kind of a curved planar reformat, you see a little contrast outpouching from the lumen into that plaque. And so this would be plaque ulceration, which upgrades this to carotid plaque-RADS 3. And finally, in panel E, we have a lesion that has a soft plaque kind of appearance, but at the center of it, there's a nodular kind of protrusion into the lumen. And so this is the appearance of intraluminal thrombus superimposed on plaque. So this is the highest risk level carotid plaque-RADS 4. Now, the first paper I want to show you is by Lukasaba and colleagues, published in the AJNR in October 2025. The title is Carotid Plaque-RADS Inter- and Intrareader Agreement and Learning Curve Analysis on CTA. The idea is whenever you propose a classification system, the first question you have to ask is basically, can radiologists even use this consistently? And as an educator, I really love this kind of study because it can give guidance on how much exposure and practice we need to ensure our trainees get, or even practicing radiologists as they're first being introduced to this system. So what did the authors do in this study? They collected CTAs of adult patients with suspected atherosclerotic disease of the carotids. They excluded those who had strokes of other etiologies such as cardioembolic and small vessel. They excluded other types of carotid disease like dissection. They excluded those who had radiation or surgery to the area as well. So this is a relatively pure population without any anatomic distortions. 490 patients were included in the final cohort. 60% of them were men and mean age was 70. About 20% of them had a stroke. And so the authors took these 490 CTAs and asked 3 radiologists to read them and rate them on the carotid plaque-RADS scale. These 3 radiologists were differentiated by experience. There was an expert who had 20 years of experience. There's an intermediate person who had 5 years of experience, so kind of like a fellow or junior attending. And there's a beginner who was a resident with 6 months of experience with vascular imaging. And they batched these CTAs into 5 separate groups so that they could look at how ratings change with additional short-term experience and therefore assess the learning curve, which is what you might really care about if you wanted to incorporate plaque-RADS into routine reporting or train your residents and fellows on it. So here we see confusion matrices for expert versus the intermediate reader, and the headline result is basically strong agreement overall. The darker the color on these confusion matrices, the higher the agreement. The mean kappa overall between the expert and intermediate readers was 0.82, which the paper classifies as almost perfect. And the highest category specific agreement was in plaque-RADS 1 and 2, while the agreement was a little bit lower for plaque-RADS 3 and 4. This pattern makes some intuitive sense because the easy calls are the normal vessel or the clearly small and uncomplicated plaque. But the harder calls are the boundary cases where you have to decide whether a plaque is thick enough or it's ulcerated or it has any of the CTA features that justify upgrading it to the highest risk group. And this slide shows the tougher comparison, which was comparing the expert against the beginner resident. The overall kappa was 0.71, which is still substantial. And the category level agreement clearly deteriorated as plaque complexity increased into plaque-RADS 3 and 4, which had inter-rater agreements of 56% and 42% respectively. So the take home here is not that beginners can't use the system, but that the difficult categories are exactly where training matters, and those difficult categories also happen to be the ones that have the greatest implications for stroke risk. And this is probably the most practical slide from the reliability paper. It shows there's improvement with repeated exposure in practice. These histograms show how the distribution of plaque-RADS ratings for the beginner changed with practice. So in the first block of 100 cases that they did, compared to the last block, the resident tended to start off saying there are too many plaque-RADS 1 rather than 2, and too many 3s rather than 4s. But with practice, the resident had a rating distribution that looked remarkably like the experts. So on a case-by-case analysis, the expert versus beginner agreement improved from a kappa value of 0.68 in the first block to 0.86 in the fifth block. And the authors interpreted that as a meaningful learning curve for the beginner reader. So I want to emphasize to listeners that this should be somewhat encouraging. The system is not perfectly intuitive on day one, but with some practice, it appears masterable. And I should note that the resident didn't even get any feedback between blocks. And so I would expect that with corrective feedback, as in the routine for education settings, that this learning curve would be much shortened than 500 studies. So we see that Plaque-RADS is relatively reliable. Now we move on to the second paper, which asks the more important clinical question, does CTA-based Plaque-RADS actually matter for prognosis? This study, co-first authored by Li-Mei Deng and Wei-Sheng Zhang, is online now ahead of the AJNR June 2026 issue. These authors examined whether Plaque-RADS improves risk stratification for ischemic cerebrovascular events beyond what we already get from stenosis severity and standard clinical risk factors. In other words, once we know that a CTA looks vulnerable, does that information translate into meaningful prediction of future stroke risk? So this retrospective prognostic study used 371 propensity score match pairs of symptomatic as well as asymptomatic patients, meaning patients who had a stroke versus did not have a stroke at the time of the initial CTA. And the two radiologists in the study independently scored CTA findings based on the CTA-based Plaque-RADS framework and also graded stenosis by NASIC criteria as mild, moderate, or severe, meaning 70 to 99% stenosis relative to the distal normal vessel. They followed these patients for a mean of 42 months for the primary outcome of ischemic stroke. During follow-up, ischemic stroke occurred in 7.3% of those individuals who were asymptomatic at baseline, so meaning a first ischemic stroke event, and a recurrent stroke occurred in 17.5% of those patients who were symptomatic at baseline. So, based on the size of this cohort and the event rate on follow-up, I think we can be confident that there was enough data to test whether plaque phenotype actually separated risk. This receiver operating characteristic curve makes the first key statistical point for this paper. When Plaque-RADS was added to stenosis grade and clinical covariates like smoking, diabetes, hypertension, the model area under the curve improved from 0.61 in blue to 0.68, and that's the red curve here, for a delta AUC of 0.07, and that improvement was statistically significant. I would put the clinical meaning this way: Plaque-RADS is not replacing stenosis and clinical risk factors, but it is adding independent incremental information that helps discriminate who is more likely to have a future stroke. These Kaplan-Meier curves are the core of this second paper on prognostication. These two curves show a stepwise monotonic relationship between carotid Plaque-RADS and the risk of stroke. The curves depict disease-free survival in the case of first stroke on the left side of the figure, and recurrence-free survival in the group who had stroke at baseline. We're looking out for a recurrent stroke. So as carotid Plaque-RADS category increases, there were worse outcomes over time. And so for listeners who are not able to see the graph on video, let me read out some numbers to you. So in the patients that were asymptomatic at baseline, the 5-year disease-free survival fell from 100% for Plaque-RADS 1 to 91% for Plaque-RADS 2, 83% for Plaque-RADS 3, and 73% for Plaque-RADS 4. In the baseline symptomatic stroke patients, 5-year recurrence-free survival fell from 95% for Plaque-RADS 1 to 86% for Plaque-RADS 2, 80% for Plaque-RADS 3, and 65% for Plaque-RADS 4. So the bottom line is that there's a monotonic stratification of stroke risk longitudinally with different Plaque-RADS levels. And this slide is the clinical money slide here. It shows the Kaplan-Meier curves when you combine traditional stenosis grading and the Plaque-RADS. So for this figure, the authors dichotomized stenosis into either severe versus mild and moderate stenosis, and they dichotomized Plaque-RADS into 3 or more or less than 3. The top line on the survival curve in blue is the lowest risk group who have mild or moderate stenosis and Plaque-RADS less than 3, so Plaque-RADS 1 or 2, right? There's a significant difference between that blue line, the red line, which is those patients who have mild or moderate stenosis and a high Plaque-RADS, so Plaque-RADS 3 or 4. This significant difference indicates a difference in risk stratification for those who would be overlooked if you only looked at traditional NACET-based stenosis grading. A little bit lower than the red line is the purple line, which indicates those patients who have severe stenosis. Of course, they have the highest risk. In a multivariable Cox model, Plaque-RADS 3 or higher independently predicted first stroke with an adjusted hazard ratio of 3.16 and recurrent stroke with an adjusted hazard ratio of 3.75, while, of course, severe stenosis was also independently predictive. The point here is that Plaque-RADS score of 3 or 4 further separated outcomes among patients who had mild or moderate stenosis. And that's the whole reason this system matters. A patient with only mild or moderate narrowing by NACET may still have a biologically dangerous plaque, and stenosis grading alone can miss that. So the summary slide brings both papers together. First, can radiologists apply CTA Plaque-RADS reliably? I think the answer is yes, especially once they have some experience. But the biggest challenges are going to be those boundary zones between 2 and 3 and between 3 and 4. But you need some practice, and you have to try it out a little bit, and then the Intrareader reliability is relatively high. And second, does it matter clinically? Well, I think the answer is also yes, because Plaque-RADS has been shown to improve discrimination beyond stenosis and provides meaningful prognostic information separating patients on follow-up as to the risk of ischemic stroke, particularly important in patients with mild to moderate stenosis. So let me put it this way. If you only report a mild or moderate stenosis and you don't report features of plaque vulnerability that are present, you may be understating the stroke risk in patients where the CTA phenotype is most useful. So the features that you should look out for are thick plaque that's at least 3 millimeters, or ulcerated plaque that would make it Plaque-RADS 3. And you should look for CT surrogates of intraplaque hemorrhage, like very low attenuation, less than 25 Hounslow units if you draw an ROI on the plaque, or rim calcifications as the rim sign, as well as the highest risk feature, which is superimposed intraluminal thrombus that's a filling defect projecting into the lumen. So I hope you can check out these two papers on the AJNR website and try out the Carotid Plaque-RADS next time you report a next CTA to get a feel for the system. Until next time, I'm Francis Deng.